We often conceptualize sleep as a dormant state, a period where the body simply powers down. The reality of the cardiovascular system is quite the opposite. Sleep is a dynamic state of aggressive physiological regulation, placing unique demands on the heart. Because of these shifting demands, patients frequently experience sleep-related cardiac arrhythmias. These are abnormal heart rhythms that either initiate during sleep or are directly influenced by the transition between specific sleep stages. The clinical presentation of these nocturnal arrhythmias spans a massive spectrum. Many are entirely benign, normal physiological adaptations to rest. Others represent dangerous, life-threatening clinical pathologies that require immediate intervention. To evaluate which is which, we look at this dashboard representing the autonomic pendulum. Throughout the night, the brain dictates continuous shifts between the sympathetic, fight-or-flight nervous system and the parasympathetic, rest and digest state. Arrhythmias are generated during sleep when the transitions between these two autonomic extremes become unstable. Mapping this autonomic balance is the required first principle. It is the only way a clinician can accurately diagnose the root cause of any nocturnal cardiac event. The cycle begins with non-rapid eye movement, or NREM sleep. This phase serves as the foundational baseline of the normal human sleep architecture. Electrophysiologically, the NREM state is dominated by intense parasympathetic activity, frequently referred to as vagal tone. We can observe this on a dual-axis timeline. As the patient enters NREM sleep on the hypnogram, the vagal tone metric steadily climbs. In direct response, the synchronized ECG tracing demonstrates a baseline slowing of heart rate and a drop in blood pressure. This intense vagal tone predictably induces benign bradyarrhythmias. The most common manifestation is normal sinus bradycardia, where the heart rate drops comfortably below typical waking levels. It also accounts for other normal NREM variants. The high parasympathetic influence on the cardiac conduction system frequently causes brief sinus pauses and first-degree AV blocks. In the strict context of deep NREM sleep and without underlying structural heart disease, these electrical pauses are expected. They establish a normal physiological baseline. High parasympathetic tone effectively protects the myocardium from overexertion, but it simultaneously creates an electrophysiological environment highly susceptible to profound bradycardia. Rapid eye movement, or REM sleep, presents a violently opposing cardiovascular environment. The steady vagal dominance that characterizes NREM is completely dismantled. Looking back at the timeline as it enters REM, the defining autonomic feature becomes clear: sudden, unpredictable, aggressive bursts of sympathetic nervous system activity. The ECG tracing instantly reflects this chaos, with highly variable beat intervals. These sudden sympathetic surges directly drive the pathogenesis of high-rate tachyarrhythmias. The chaotic electrical environment significantly elevates the clinical risk for supraventricular tachycardia, or SVT, and recurrent episodes of atrial fibrillation. This sympathetic instability also acts as a primary trigger for ectopic beats. Patients frequently exhibit premature atrial contractions, or PACs, alongside premature ventricular contractions, or PVCs, during these surges. REM sleep essentially functions as a natural physiological stress test. The normal autonomic erraticism of this stage actively provokes latent tachyarrhythmias. When we introduce pathology into this delicate balance, the results are severe. Obstructive sleep apnea, or OSA, is the single most critical catalyst disrupting the normal sleep-cardiac relationship. The OSA cascade initiates mechanically. During sleep, the soft tissues of the pharyngeal airway relax and collapse backward, completely sealing off the air passage. This polysomnography, or PSG dashboard, maps the immediate chemical consequences. As the airflow trace flatlines, systemic oxygen levels plummet, creating hypoxia. Simultaneously, carbon dioxide rapidly accumulates in the blood, leading to hypercapnia. Below that, we see the patient's physical struggle. The diaphragm forcefully attempts to pull air against the closed airway, generating severe intrathoracic pressure shifts that physically stress the heart muscle. The electrical response is immediate. The hypoxia triggers an intense spike in vagal tone as the body attempts to conserve oxygen. This induces severe pathological bradycardia. The physiological climax arrives when the brain registers critical blood gas levels. It forces an abrupt neurological arousal, momentarily waking the patient to forcefully clear the airway. This arousal triggers a massive sympathetic explosion. The extreme bradycardia is instantly reversed into compensatory tachycardia. This repetitive cycle is known as brady-tachy syndrome. The heart is violently thrown between parasympathetic and sympathetic extremes, often dozens of times per hour throughout the night. Obstructive sleep apnea is a recurring nocturnal electrical trauma. It systematically degrades myocardial stability night after night. The ultimate clinical outcome of this pathophysiological cascade is high yield. Obstructive sleep apnea is a major driver of recurrent nocturnal atrial fibrillation. Patients enduring this cycle frequently report nighttime palpitations, abrupt awakenings accompanied by gasping, and lingering chest discomfort upon finally waking up. The true clinical danger lies in the stealth of these events. Despite the severe mechanical shifts occurring inside the chest, many nocturnal arrhythmias remain entirely asymptomatic, undetectable without targeted continuous monitoring. When we do monitor these patients, we look for specific electrophysiological red flags requiring immediate intervention. This ECG tracing isolates the first major warning sign: severe sinus pauses exceeding 3 seconds in duration. Additional red flags include any sustained tachyarrhythmias or patient reports of syncope that perfectly correlate with extreme drops in blood oxygen saturation during the night. Ignoring these markers carries grave consequences. For patients with pre-existing structural heart disease, these untreated severe arrhythmias dramatically increase the risk of sudden cardiac arrest and nocturnal death. Recognizing the precise clinical markers of OSA-driven arrhythmias is the exact dividing line between managing a benign sleep variant and preventing sudden cardiac mortality. Diagnosis relies on polysomnography. PSG is the definitive tool because it meticulously correlates specific electrical cardiac events directly with sleep phases and physical airway collapses. Clinicians supplement this with continuous ECG and 24 to 48-hour Holter monitors. These monitors capture unpredictable arrhythmic episodes that might occur outside the controlled environment of a dedicated sleep lab. When establishing a treatment strategy, one foundational rule applies. Addressing the underlying sleep disorder is the absolute prerequisite for any long-term cardiac management. This makes CPAP therapy the unequivocal first-line treatment for OSA-related arrhythmias, as seen on these split dashboards. By pneumatically splinting the airway open, it prevents physical collapse, entirely eliminating the hypoxia, hypercapnia, and massive arrhythmogenic sympathetic surges that follow. For patients without OSA, or those with refractory structural issues, secondary cardiac management steps in. This includes antiarrhythmic medications, targeted catheter ablation, or the implantation of a pacemaker to manage severe, persistent bradycardia. Ultimately, the proper management of sleep-related arrhythmias demands treating the sleep environment itself as a primary cardiovascular lever. By actively restoring autonomic balance to the patient's sleep cycle, we stabilize the heart and we save lives.